Good afternoon to everybody from Thessaloniki. Hope you're all well. I would like to initially thank the organizers and the chair of our session, Professor Dardiotis, for the kind invitation to take part in this seminar. Now, I am going to speak about a screening test known as the Quick Mild Cognitive Impairment Screen, and I'm going to provide data on comparative data for this screen with a very well-known cognitive screen, the Montreal Cognitive Assessment in the Greek elderly population. Δεν αλλάζει η διαφάνεια, δεν ξέρω γιατί, my slide does not change.
I would like also to welcome you here in this session.
Okay.
Which is organized by the Hellenic Initiative Against Alzheimer's Disease. We are very proud.
Okay, now I can change it. All right, thank you. Would you like to continue? Would you like me to continue?
Yes.
I couldn't change the slide, it wasn't changing. Okay, now, the truth is that the ever-increasing number of people developing cognitive impairment and ultimately dementia calls for early detection of cognitive decline in the older populations. Ideally, this should take place before the manifestation of objective cognitive impairment or brain changes to prevent or delay the progression to dementia. However, the differentiation of mild cognitive impairment from early dementia or normal cognition from subjective memory complaints is not always a straightforward process, and this, of course, makes it even more difficult when we are speaking about primary care settings. There is strong evidence that cognitive impairment is actually under-recognized in primary care settings, and up to from 40 to 75% of such cases actually go undetected when these patients visit their general practitioner. So why should we actually screen? First of all, it's very, very important for screening to take place of cognitive impairment because this can actually improve the way we take decisions. Secondly, screening may allow for the prompt initiation of appropriate treatments and care. And another very important issue, it actually allows for the identification of any reversible causes of cognitive decline. And the truth is that 10 to 30% of cases referred to special memory clinics are cases with reversible causes of cognitive decline. And of course, an initiation of a different style, lifestyle advice. What do we currently use in Greece to screen these types of patients? Two very common cognitive screening instruments that are widely used in Greece is the Mini-Mental State Examination and the Montreal Cognitive Assessment. Now, these tools have several strong, of course, psychometric characteristics, but they do have some limitations. For example, the Mini-Mental State Examination, although widely used by many physicians, it does have a certain bias for higher education levels, and it also may have a low ceiling and a high floor effect. This actually means that it may not pick up early cognitive losses or patients with mild cognitive impairment. On the other hand, the Montreal Cognitive Assessment has a relatively narrow scoring range. It seems by several studies to be difficult for measuring the actual progression of dementia. And some studies say, and clinical experience says, that it may be too long for the busy clinician or for the hospital outpatient. Therefore, we decided to adapt into the Greek language and validate, as I said in the beginning of my speech, a cognitive tool known as the Quick Mild Cognitive Impairment Screen. Qmci-Gr is the Greek name of this tool. This tool has been translated and adapted in various languages. Among these languages, of course, is the Greek translation and adaptation. And our group of clinicians and researchers had the luck to translate and adapt this tool in Greece. Initially, what we did in order to overcome the limitations of the mini-mental state examination and the MoCA is we compared this tool to the standardized mini-mental state examination, a tool that is also used very often in clinical practice. And what we found in this initial validation study is that it compared favorably with the SMMSE and appeared also to be more accurate in discriminating patients with subjective memory complaints from patients with cognitive impairment, in other words, MCI and demented patients. This was our first study that involved the SMMSE. Now, just to give you some details on the quick mild cognitive impairment screen, the actual test is composed of 6 subtests: orientation, registration, recall, clock drawing, verbal fluency, logical memory. As you will see from this table, these subtests measure domains that are very, very important in the detection of patients early on in the neurodegenerative processes, such as patients with MCI, subjective memory complaints, or of course early dementia. You can see that they actually assess orientation, which is very, very important, attention and working memory, visospatial construction, verbal and working memory, episodic memory, very, very important domain for demented patients and MCI patients, semantic memory and language, and of course, another test of episodic memory that also has very, very good ecological validity. Now, the test takes approximately 5 minutes if done correctly and the clinician that does the testing is trained. Now, of course, these subtests appear, some of them, to actually better discriminate between normal cognition, mild cognitive impairment, and dementia. And in the study that I am showing you, the authors actually assessed which of the subtests appear to best discriminate between these conditions. And what the study showed is that when they compared MCI patients with normal aging, normal cognition, it was found that the subtests that measures logical memory, in other words, a subtest of episodic memory, had the highest discriminative ability with an AUC of 0.80, which is quite high. And when they actually compared MCI to dementia patients, here, which was something that was expected, they found that the subtest that actually measures orientation was the one that better discriminated between these two groups. Of course, they also developed various cut-off scores. On the left side of the screen, we can see which of the recommended cut-off scores for MCI and dementia with very high sensitivity and specificity levels. And on the right-hand side of the screen, we can see a table with age and education adjusted cutoff scores. We all know that age and education are very, very important characteristics when we measure cognitive processes. And of course, it's usually very important to have data that are actually corrected for age and education. Now, when the Qmci was compared to the second well-known test that we use in Greece, to the MoCA, the authors that were in Ireland in the Department of Geriatric Medicine, Professor Molloy and Donovan, what they actually found was that when they compared patients with cognitive impairment versus normal control patients, they found, when they compared these 3 instruments, that the Qmci had the best discriminative ability with an AUC of 0.94, which is very high. When again they compared MCI patients with normal controls, again the Qmci appeared to have the better discriminative ability. And again, when they compared MCI patients versus demented patients, again, the Qmci in their study appeared to have the better discriminative ability of the three measures. Now, regarding our study, which we recently submitted for publication, in our study, we had 149 consecutive patient participants with a median age of 71. We included 49 patients with subjective memory complaints. That basically means that although they complain that they have memory problems, when we test them neuropsychologically, we don't actually find cognitive decline. We also had 32 patients with mild cognitive impairment using the Patterson criteria. And we had 72 patients that fulfilled the criteria for dementia according to the DSM-5 criteria. And of course, in order to establish the dementia stage, we used the Reisberg Functional Assessment Staging Scale. Our patients were at least 55 years old, and they had a geriatric depression scale of lower than 5. These patients were recruited from two settings, from the outpatient memory unit of the University Hospital of Patras and the Alzheimer's Center of the Greek Psychogeriatric Association in Athens. Now, we excluded patients that were unable to communicate fluently in Greek, a patient that had another neurological disorder or a major psychiatric disorder. We also excluded patients with traumatic brain injury and addiction problems. These patients all underwent detailed neurological examination, laboratory testing. We also assessed them with a comprehensive, flexible neuropsychological battery. They also underwent neuroimaging. And then we actually compared, we gave them the two tools and we compared the two tools. Of course, in order to minimize the learning effects, what we actually did is we administered sequentially and alternated, of course, the two tests. And of course, they were done by trained raters. There was one rater in each side that scored the Qmci screen and the MoCA. And of course, the raters were blind to each other and the final diagnosis. These are the characteristics of our sample that we have submitted for publication. And we see here that there is, of course, a difference, a statistically significant difference in terms of the median years, okay, of each patient in terms of education. And then when we actually go to the cutoff scores, these are the suggested cutoff scores for subjective memory and from MCI, a cutoff score of 71. The maximum score of this tool is actually 100. In order to differentiate MCI from dementia, a cutoff of lower than 55 is recommended, whereas for subjective memory complaints from dementia, a cutoff of 53 is suggested. Now, regarding the MoCA, in order to discriminate SMC from MCI, a score of 26 is suggested. MCI from dementia, a score of 22, and SMC from dementia, a score of 25. And we can see that depending on which two cases we compare, the sensitivity and specificity levels are from average to quite high. Now, what do these results actually mean? First of all, it appears that the Qmci, the Greek version, had higher accuracy compared to the MoCA in terms of discriminating MCI patients from demented patients. However, although the AUC was higher, when we did our statistical analysis, we found that this finding was not statistically significant. When we tested the accuracy of the Qmci in order to distinguish subjective memory complaints from dementia, we found that in this specific case, the Qmci had better accuracy, and this accuracy was also statistically significant. However, when we tested the Qmci to the MoCA, we found that the Qmci had lower accuracy than the MoCA in the Greek sample in differentiating subjective memory complaints from MCI, a finding that was unexpected when we compare the findings of the international literature for this test, this final finding. Now, what did we conclude? We concluded that the QMCI, the Greek version, has comparable diagnostic accuracy to the MoCA regarding the mild cognitive impairment and dementia groups. But although both instruments had similar accuracy in terms of differentiating MCI from dementia, the established brevity of the QMCI, in this case, it took us a median time of 4.2 minutes to complete the test with a range of between 3 and 5 minutes, whereas we know that the MoCA takes approximately 10 to 12 minutes. And of course, it has a very easier use in terms of scoring and in terms of learning how to give the test. So therefore, we concluded that the Qmci-Gr may actually be a better choice than the MoCA, at least in the Greek setting, for detecting MCI and dementia, especially when this is necessary in busy clinical practices in Greece. And of course, many neurologists don't normally have more than 5 minutes, maybe a bit more, in order to test cognition when they actually examine their patients. But of course, further research with larger and more diverse samples may be necessary in order to ensure that these results are generalizable. Thank you very much.
Thank you very much, Professor Messinis. Just to introduce him, because the problem was at the beginning, Lambros Messinis is a clinical neuropsychologist. He's an associate professor in the School of Psychology and the Aristotle University of Thessaly. So, Professor, we see that we have another tool available to help us in the diagnosis of MCI. Mm-hmm. It is shorter, it is reliable, so we can see if we can implement it in everyday practice. Mm-hmm. So now we're open to questions or comments on the topic. You can write down any question in the chat, and also you can address it to Professor Messinis. Professor Liketsos?
Good afternoon, everybody. Thank you for the presentation, Professor Messinis.
Thank you very much.
If I understood correctly, your origin for this effort is to develop a primary care-based screening tool. And so with that in mind, I had 2 questions. First, should you not be therefore evaluating its validity in a primary care environment as opposed to a referral environment? And then my second question is, in the US, many randomized trials now suggest that screening in primary care is not helpful. And so we have largely abandoned that effort. Is screening in primary care something you think is going to be more fruitful in Greece, and therefore that screening tools would be needed?
Thank you for your questions, Professor Liketsos. I'll actually answer the second question first, if you don't mind. The truth is that, unfortunately, in Greece, the availability of specialized clinical neuropsychologists is not very high. In other words, very few hospitals in Greece and other types of settings and private medical practices don't actually have specialist neuropsychologists. So screening tests in Greece are still very, very important tools. At least in order to, as a first step, in order to try and detect patients with such types of problems. So at least in the Greek settings, although I do agree with you that in the US they are less important at this stage and less useful, possibly. In Greece, because of the absence of qualified clinical neuropsychologists in these settings, our GPs, our neurologists, our psychiatrists tend to use these tools quite often. In this respect, at least in the Greek setting, they do still remain important. Now, as regards your first question, we didn't actually develop this test. This test was developed by Professor Molloy and Donovan in Ireland in their geriatric medicine unit. We just translated and adapted this test in Greece. Thank you very much.
Labro, I would like to ask you if this is free available in the for professors.
Yes, the tool is available in my slides. On the last slide, you will see I do have a link. I don't know if you can still see the slides. Yes, available at www.qmci.ie. It's available in these languages.
If there is any special training in order to
look,
certificate to be reliable.
I wouldn't actually call it special training. I would just actually call it some training. But I think for a specialist neurologist or psychiatrist, if he actually has an hour or two of training and he actually gives the test to 3 or 4 patients with the presence of a neuropsychologist, I think that he won't have many problems in learning to apply this test. So I wouldn't actually say very specialized training, but of course, yes, he needs to be taught how to use the tool.
Okay. Okay. Any other questions or comments on this tool, or generally in testing the cognitive function of patients? Okay. Thank you, Professor.
Thank you very much, everybody, for the invitation and for listening to me. Thank you very much. Good afternoon to everybody.
Yes. So we can move to the second presenter, who is Grigoris Nasios. He is a neurologist and associate professor in the School of Health Sciences in the University of Ioannina. And he is going to tell us about the feasibility and efficacy of telerehabilitation program in Greek patients with mild cognitive impairment during the COVID era. So, Professor Nasios, the floor is yours.
Thank you, Professor Dardiotis. I also want to thank all the people who started and work hard for the Hellenic initiative against Alzheimer's disease. Personally, Professor Leketsos, who is together with us today. I want to congratulate Lambros for the excellent talk, and I want to thank you and Lambros for the good and the journey we are traveling together all these years, trying to improve our services to the patients. So I am going to discuss preliminary results of a study of our own about the efficacy and feasibility of a telerehabilitation program in amnestic multi-domain MCI patients. Okay, so we all know that MCI is defined as a condition between cognitive decline of normal aging and Alzheimer's disease. The majority of studies estimate that the prevalence of MCI ranges from 16 to 20%, while in Greece recently was estimated at 30.1%. We can classify MCI into 2 subtypes: amnestic, with the core problem of memory, and non-amnestic, characterized by impairments in domains other than memory, like language, visuospatial, or executive. So cognitive deficits include executive function, memory, and attention, while language deficits include naming, speech production, or comprehension. However, all these deficits are not extensive enough to interfere with daily activities, as the definition of MCI informs us. So the effect of cognitive training is increasingly recognized as a promising approach, and it has already been proven effective. It consists of computer and paper-based cognitive exercises in individuals with MCI. Studies have mentioned small to moderate effects after cognitive training using computer software in many domains, such as quality of life, attention, delay memory, working memory, episodic recall and recognition, executive function, semantic fluency, and naming. Actually, in the year 2018, we have practice guideline update summary from the American Academy of Neurology, where clinicians are able to recommend cognitive training with level C of evidence, which is not very high, but it is included to the guidelines. Since then, a lot of literature has increased. We had already 2 studies proving beneficial effect of computer-based multi-domain cognitive training. This is the first study in patients with mild cognitive impairment. And we had also a second study with a similar design with patients in the early stage of Alzheimer's disease. Both studies showed efficacy of this multi-domain training to the people who participated in this program. What about telerehabilitation in MCI? Very few studies has been published regarding the effect of cognitive telerehabilitation programs on individuals with MCI. They found an improvement in domains of delay memory, attention and language, and working memory. The aim of our study, which was also motivated in the era of pandemic lockdown, was to evaluate the efficacy and feasibility of a telerehabilitation program in patients with amnesic MCI using computer software that focuses on several cognitive domains, such with language exercise with paper and pencil that focus on language deficits. So this is our flow diagram. We had initially recruited 40 subjects within MCI. 14 of them were excluded for various reasons. 16 of them were randomized into 2 groups, 14 to start the active therapy, the telerehabilitation program, and the other 12 to be as a waiting list, receiving only routine clinical service. So from them, we had a dropout of 5 subjects, lost or follow-up mainly in the control group, while in the active program group, we have 5 subjects which discontinued intervention before the end. So at the end, we had a rather small number of participants, 9 in the active group and 9 in the control group. So our sample, as I said, included 18 patients with MCI. The training group, which received cognitive training by using the REHACOM software, as well as paper, pencil, language training. I show you in every single session, we combined both procedures, and the control group, which received standard clinical care only. So the duration of the telerehabilitation was 15 weeks, rather long duration. We wanted to be in consistent with the previous work of us, which were intervention face-to-face. So we wanted to have 15 weeks, and it was twice a week, 60 minutes per session. And this is our demographic characteristics of our subjects, which are almost comparable. And all participants received an initial cognitive assessment and language assessment. And the assessment was conducted face-to-face. 1 week before the beginning, that was the baseline assessment, and 1 week after the telerehabilitation program. So the assessment included all these sets: Montreal cognitive assessment, delayed work memory, digit span and forward and backward, trail making test, semantic fluency, and Boston naming test. So in every session of the rehabilitation, twice per week, we had 2 parts. In the first part of every session, cognitive training using the REHACOM cognitive therapy software were conducted, and we worked with delay and working memory, recognition, executive function, processing speed, and visual attention. In the second part of the telerehabilitation program, the other 30 minutes of every session included language exercises with paper and pencil concerning naming, semantics, verbal fluency, syntax, and morphology. So what we saw was that the performance of the control group either remained stable or deteriorated. And this is in agreement with previous research, which investigated the effect of computer cognitive training in such patients. On the other hand, the performance of the treatment group after the telerehabilitation program was not significantly better on some domains. On the other hand, the performance improved on measures of delayed memory, word recognition, naming, trail making, recall, and the scoring in MoCA. However, without significance, but we have in all these a tendency of improvement. So these findings are in accordance with other studies on patients with MCI, which investigated the effect of video conference intervention, and they mentioned improvement in attention, language, global cognitive performance, working memory, and executive function after training. So this is the table of our results, and what was significantly better was the performance on delayed memory, which was post-interventionally significantly better than the control group's performance. This finding has been confirmed by other studies which mentioned that the individuals with MCI demonstrate deficits in a wide range of everyday functions, but that the magnitude of these changes is greatest for those functional abilities that they rely heavily on memory. So our result is also in agreement with the recent study of Zhang et al., who explored the impact of computerized multi-domain cognitive training on brain gray matter volume and neuropsychological performance in patients with amnestic MCI, finding no significant changes in neuropsychological performance, but revealed positive correlation between the changes in gray matter volume in the right angular gyrus and scores on immediate and delay recall. And this is the table showing the significant effect in delayed memory in our treated subjects. So what we conclude, in the recent coronavirus emergency, brought into light the importance, but also the difficulties of remote delivery of cognitive training to support rehabilitation services and assure continuity of care to patients with cognitive deficits. Our preliminary data also constitute evidence regarding the negative impact of the COVID pandemic and the related restrictive measure resulting in social isolation and forced physical inactivity on patients with amnestic MCI. When left without intervention, there was a significant deterioration of the cognitive function. Our study shows a significant effect of the telerehabilitation program. Treatment groups improved performance, was significantly better on delayed memory, while their performance also improved in other domains, however, without reaching significance, as I showed you. Of course, more studies with larger samples are needed to see these promising preliminary findings. This work is now under review and pending the final reviewer's answer. And I would like to thank you very much for your attention.
Thank you very much, Professor Nasios, for your study and for presenting us this original data. So it seems that the telerehabilitation is better compared to the standard of care in the domain of delayed memory. And maybe we should encourage our patients and their relatives to participate in these efforts. instead of having nothing. And we can see that this can be translated into clinical practice in order to advise them taking part in these interventions. So, any question or any comment? Professor Lukiatsos?
You were reading my mind. Wonderful work. Thank you for presenting. Sort of reflecting on a couple things, because as you know, I'm sure lots of in-person cognitive rehabilitation efforts for MCI have not been shown to have an advantage in clinical trials. So it's good to see that telerehabilitation might have an advantage over a controlled condition. But this was occurring during the COVID epidemic, when there was very little else that these patients were doing. So I'm curious whether you think that's important. In other words, if people are out doing their usual thing, do you think you would have the same advantage, as opposed to seeing an advantage for people who are largely shut in because of the pandemic? That was the one question. Another question we always ask in the States, maybe because things are pricey here, is what is the cost of delivering this to the individual? Because you always got to figure, if an individual has to pay for this out of pocket, how much advantage are they getting for the euros that they're spending?
Thank you for your questions, Professor Ligesos. Actually, what we saw in the control group and almost most research groups also described was a deterioration, and the pandemic lockdown perhaps forced all people to be closed in homes, forced inactivity. It was, I think, bad period for all, but worse period for people living with dementias and MCI. So I think that giving the opportunity to these people to have an activity in a regular basis, perhaps it was a privilege for them. So, of course, we have to see after the pandemic, because one major advantage of this telerehabilitation service is that can be remotely offered to people who live in places far away from centers, from daily centers or specialized practices. So as far as your second question, I think, of course, in terms of research protocol, the cost for the patients was zero. But RehaCom, which was the software used by our group, is not expensive. Actually, we buy every training hour in the software for just a few euros. I think it is €5 per hour. So I think the cost of the software use is not high. And of course, one of our colleagues must be occupied and inspecting the presence and the performance of the participant. But I think the cost can be very low.
Yes, in our experience, we have this program in our daycare unit. So the government bought it for us. So there is available in our daycare unit. So you can implement it in patients, especially those that cannot come to our daycare unit. And of course, this gives them the opportunity to have some kind of cognitive rehabilitation instead of having nothing. And also the preparations, the expectation, the family or the patient itself is very high, and this can give some benefit to these patients. Any other questions, please? Or comments?
Can I ask, Simon?
Yes, Professor Skarmes.
Thank you for the presentation. A couple of comments and questions. It seems more like, it seems more like a feasibility study, of course, rather than efficacy study, and we all understand it. And I guess because of the comparison arm being, standard of care, so it's not clear, whether we're seeing an effect of any intervention or an effect of a remote intervention versus a standard intervention, because there was no cognitive rehab, in a traditional way with paper and pencil. But I understand, that that's the aim. So I want to ask you, I mean, did you see any practical issues, any difficulties? Did people like it? Did people adhere to it? It seemed that they did. Did you get any comments, any feedback? Is it something that people may be willing to follow? And the reason I'm asking is because, we're sort of starting a similar effort, like a collaboration, trying to do some pilot multi-domain intervention that includes some cognitive aspect too in a slightly different population. And we're trying to optimize and see what would be best and what would be the optimal way to deliver this intervention. So I would like to hear more about how people felt about the intervention, the participants I mean, and also why did you choose this intervention? I mean, how does it compare to other options that include more, human interaction, neuropsychologists? And also in relation to this particular program, I guess it's a cost per session, but is there an option to buy it and have unlimited number of sessions for many people, maybe at a different price? So if you could tell us a little bit more about these aspects.
Thank you, Professor Skermes. Actually, what you commented in the beginning was the major limitations of this preliminary study. Of course, we cannot rely on statistics for efficacy with 9 subjects per arm, of course, so this is underpowered. So, of course, feasibility perhaps is the major discussion. I think the major problem was the long duration. 15 weeks, more than 3 months, was long for many. And most of these 5 participants who didn't finish the study was because they didn't want to continue for the 3rd month, perhaps. Actually, also the waiting list, the control group that did doing nothing rather than standard care, was chosen just because it was also what we decided to use as a protocol in our face-to-face rehabilitation program, which was already published. So we wanted to have similar study protocol. We also then combined RehaCom training and paper and pencil training within the same session. We also decided to have a long duration, 15 weeks, 2 times per week. And our control group was only receiving standard care, nothing more. So I think that if we were about to design again the study, first of all, we would like to have a larger sample, of course. Secondly, to have something better than standard care in the control group. And perhaps we will think of a shorter duration. People who participate and people who finished this protocol, I think in their majority enjoyed it. I think it was not something difficult. It was not something that judged as unpleasant. On the contrary, especially the software, the RehaCom part, was funny because it was just a video game for them. The problem was to find a willing and capable caregiver, because we had to have a computer, we had to have an internet connection. The participant had to download the software, enter with codes. So we have to have a reliable participant. And that was one of the difficulties we have to recruit subjects, because We had enough patients, but perhaps not enough reliable caregivers.
Just to add that there is an unlimited version of the program. We have one in our daycare. The cost is about €2,000 for 1 year. So you can have this program unlimited, and we will do many studies, especially in students, also during the training of the patients. So we can use it in an unlimited manner.
And what do you think is the advantage over doing, let's say, a Zoom teleconference and doing a more traditional, cognitive rehab like the one they do in day? Why do you think it's better? Is it more attractive? Does it have a video game part?
I'm sorry, we cannot hear you.
Nico, can you repeat it? Can you repeat it because the sound was not so good?
Saying why not go with something more traditional? I do not advocate it. I'm just asking what's the advantage over having a neuropsychologist and doing what they do in daycare centers, but do it over Zoom. So what's the advantage of using a program like that? I just don't know a lot about these interventions, and I'm trying to figure out.
Would you like me to answer the question? May I answer?
Yes, because Lambros have introduced it in Greek language.
Good afternoon, Professor Kameas. Thank you for your question. I think that the main advantage of computerized software is the fact that we don't always necessarily have to use specialized professionals, clinical neuropsychologists or speech and language pathologists. There, of course, the cost is much higher. When you need to use a clinical neuropsychologist to do traditional therapy, of course, you cannot do it with €5. So one of the advantages is the cost. The second advantage is that there are many studies available on this specific software, not only in patients with neurodegenerative disorders, but also patients with stroke, multiple sclerosis, psychiatric disorders. So there are many studies that have proven the efficacy of this tool, and also studies that have compared traditional cognitive stimulation rehabilitation with computerized, and they seem to compare favorably to each other. So in other words, there aren't many differences. Of course, the software on its own is not rehabilitation. It's not neuropsychological rehabilitation. Neuropsychological rehabilitation involves many other things. The program offers cognitive stimulation. Neuropsychological rehabilitation needs many more things. You need to do psychoeducation, psychotherapy, a lot of other things when you speak about neuropsychological rehabilitation. But in this case, and the fact that we were able to provide these patients with some type of stimulation during a period that we had these very serious problems, I think that is also very serious, a very important advantage of this tool. But I think both traditional and computerized, of course, have their limitations and have their positive aspects.
Another thing I would like to add is that this program automatically adapts to the performance of the patient. So compared to the level of the performance, it adapts and exposes them to more difficult exercises based on the current performance, cognitive performance.
Okay. Thank you. Maybe other people want to ask. I don't want to monopolize.
Okay. Any other comment or question to both presenters? So, Professor Liketsos, would you like to wrap up and?
Well, on behalf of HIAAD, I would like to thank you, Professor Dardiotis, for putting this together. And both the speakers, Professor Mesinis and Nasios, nice work. I'm really glad to see the broad participation and all the other people attending, which is terrific. This is the launch of our 2023 series of seminars. So I hope that we will have the opportunity to meet with you again on the third Thursday of every month at 5 p.m. Athens time. So it's a great launch, nice work. And Themi, see you in a couple of weeks in Baltimore.
Yes, I'm looking forward to be there. Thank you very much. Bye-bye all. Next meeting is on the 21st of April, the Great Thursday. Just before we go to the church, we have this meeting.
Thank you very much to everybody. Keep well. Thank you.
Bye bye.
Bye-bye.
Χαίρετε και ευχαριστούμε.
Γεια σας, γεια σας.